Hi, Assalamualaikum. I am Nurul Suhaili binti Ibrahim, Bachelor of Medical and Health Science, second year. My ID is 930-509-751-54001. This is clinical practice emergency and trauma for study case complete heart block. I am from case Bachok Kelantan for 3 years, diploma in medical assistant. Now I'm working at Clinical Penang as a cardiac technician since 2014 until now. I base on cath lab, cardiac catheterization labs for angiogram procedure, angioplasty. Okay, this study case is about complete heart blocks. I just posting to a hospital Bukit Mertajam for 2 weeks for my clinical practice emergency and trauma posting. I take this study case complete heart block because it is very common in older people. Okay, we can see the patient profile. Name is Mr. Ong Ching Fo. He is a male. Race is Chinese and age 64 years old. Uncle is smoking 2 pack a day and non-alcoholic. Social history was taken. He retired from military and uncle got allergic to penicillin, antibiotic groups. Medical history, uncle is follow out in Klinik Kesihatan Bukit Minyak for diabetic type 2, hypertension, dyslipidemia every 6 months a year. Okay, uncle has a non-surgical history. Okay, on the date 18 November 2020, around 1 o'clock. Okay, my study case is about Mr. Ong Ching, 64 years old male, was transported from Klinik Kesihatan Bukit Minyak to emergency department, accompanied by medical assistants. The primary triage is tagged non-trauma case in the red zones at 1 p.m. This case is referred from Bukit Minyak to Bukit Mertajam Hospital. Patient FVPU scales is alert and the peripheral capillary oxygen SpO2 is 95 to 98% via face mask. Patient airway is pattern. On emissions, we take the blood pressure and the blood pressure is 56 per 30 mmHg with a slow radial pulse about 34 beats per minute. Patient chief complaint short of breath and chest discomfort. Okay, we take the referral later. On 1812, during the annual screenings, doctor was ordered ECG as patient complained of the heart rate was low since 3 to 4 months during daily checking, blood pressure monitor at homes. Patient didn't come to see doctor, seek for treatment because patient unsure of a normal rate of 60 to 100 beat per minute. So he just wait for the follow-up, the date of follow-up. Okay, Okay, patient history taking was take. The past illness is nil. Present surgery is nil also. Past surgery also nil. Okay, family history, as usual, got hypertension, diabetic, and high cholesterol from the father side. The investigation during admission was taken in emergency department. We take the ABG. As we see, ABG result, the PO2 is low, for only 45.3 mmHg. The number is about 83.0 to 108. Okay. We also take the kidney functions. The creatinine 180 mg per dl, GFR is 63. This means the patient might be the kidney deteriorate. Coagulation test is normal. Okay, after blood pressure was taken, we take the ECG. As you can see the result, there was QRS, P, P wave and QRS, and then P and QRS, P and QRS. As you can see, this is the complete heart block because P and QRS is two independent rhythms. Okay, after that, for management heart block, we just assess the high risk patients, monitor ECG patient every 30 minutes, assess the family history of heart disease, assess of smoking and alcoholism, monitor lab value, frequently especially serum cholesterol level. This will take at the ward. We also assess of CAD. CAD meaning coronary artery disease, and just monitor the vital signs. Okay, for further management, order by medical officer, transcutaneous pacing, TCP, patch, apply to the patient chest, anterolateral position, and anterior posterior, AP position at 20 MA without capture. Pacing is initiated. Until capture is observed at 110 MA. The amperage is increased incrementally within a minute. The level of conscious of the patient increase, and each TCP discharge shows sign of discomfort. Okay, and then morphine sulfate was given in increment of 2.0 mg before it became convenient for the patients. We also give Mesolon 10 mg. Mesolon 10 go. Step. Okay, patient referred to the nearest general hospital for permanent pacemaker implant, DDIR, dual chamber anti-bradycardia pacings, and further investigations. As we can see now, we now have a definition heart block. Incomplete heart block, there is a complete absence of AV conductions, none of supraventricular impulse or conduct to the ventricle. That means signal delay and or block when moving from the atria to the ventricle. If you can see at the picture, there was an electrical system of the heart. We got axis node, sinoatrial, anterior interior tract, middle internodal tract, posterior internodal tract, Pachman bundle, left thunder branch, and conduction pathway, anterior ventricle AV nodes, and right bundle branch. For the normal conduction, we go to sinoatrial node first, to the atrial muscle, AV node, bundle of his to the left and right bundle branch. The last one is ventricle muscle. This is ECG placement. We can see the electrode is V1, V2, V3, V4, V5, V6. V1 placed at 4 intercostal space at the right sternal border. V2 4 intercostal space at the left sternal border. V3 halfway between lead V2 and V4. V4 fifth intercostal space in the middle clavicle line. V5 left anterior axillary line under same horizontal plane as V4. V6 left mid-axillary line under same horizontal plane and V4, V5. RA, right forearm or wrist. LA, left forearm or wrist. LL, left lower leg proximal to ankle. RL, left lower leg proximal to the ankle. This ECG placement is to see the SA node, AV nodes for PQRST. Okay, the P is the atrial depolarizations initiated by the SA node, cause the P wave. Okay, for the P to Q with atrial depolarization complete, the impulse is delayed at the AV block. QRS is ventricle depolarization beginning at the apex, causing the QRS complex atrial repolarization occur. And S to T is ventricle depolarization is complete. T means ventricle repolarization beginning at the apex and it causes the T wave. Ventricle repolarization is complete after the T wave. So we can see heart block type. The first is first degree heart block. Second one differentiate by second Morbius type 1 or Wynn-Kimball. Then got Morbius type 2. The last one is third degree heart block. Or we call it complete heart block. Okay, this one is first degree heart block. They are slow electrical pass from the XA node to the AV nodes, but all of them eventually reach to the ventricle. So you can see on the ECG, the PR interval is longer, is more than 5 blocks, 5 small blocks you can see here. First degree heart block really cause symptom or problems and generally do not do not require any treatments. Okay, this one is second degree heart block. We call it Morbius type 2, type 1 or Wynn-Kimball. Okay, Wynn-Kimball is the type electrical signal delay further and further with each heartbeat until a beat is missing completely. We can see here got like a long pause. Then on the ECG, the progressive of prolonged PR interval is seen without a QRS complex. This is known as a block P wave or drop QRS complex. The circle restart over as this usually repeat irregular circle. there is fixed ratio between the number of P wave and the QRS complex per circle. The number of QRS complex always equal to the number of P wave minus 1. In this example, there are 4 P wave for every QRS complex. This is 4 to 3 hard block. Second degree AV block type 1 block are usually mild and no specific treatment is indicated. Okay. The second degree hard block, Mobis type 2. In this type, second degree hard block, some of electrical signal do not reach the ventricles. On the ECG, this is seen as intermittent non-conducting P wave. They are PR interval, however, remain constant in conducted beat. In majority case, the successfully than usual in some type 2, there is a fixed number of P wave per QRS complex. In this example, there are type P wave. Every QRS complex and conduction is described as 3 to 1 block. However, as the type 2 hard block is unstable, this ratio is likely to change over the time. Second degree type 2 is less common than second degree type 1, but is much more dangerous as frequently progressive to complete heart block and cardiac arrest. Implantation of artificial pacemaker is recommended for treatment of this type of AV block. Okay. Okay, the last one, complete heart block, or we call it third degree heart block. Third degree heart block, in these conditions, non-electrical signal from the atria reach, reach to the ventricles with no input coming. From the atria, ventricle usually try to generate some impulse by itself. This is known as an escape rhythm. On the ECG, two independent rhythms can be seen. Regular P wave pattern, but represent atrial rhythm, and the regular but usually show QRS pattern represent the escape rhythm. The PR interval is variable as there is no relationship between the two rhythms. Patients with third degree heart blocks are at a high risk of cardiac arrest. They require immediate treatment, cardiac monitoring, and a pacemaker implant. This is easy one, the heart block poem. If the R is far from P, then you have a first degree block. The longer drop, then you have a weaker beach. If P don't get through, then you have Mobis type 2. If P and Q don't agree, then you have a third degree. Okay, if you can see, the cause of heart block is leaf disease, idiopathic fibrosis of the cardiac conduction system, ischemic heart disease, cardiomyopathy, and myocarditis. Okay, the prognosis of patient with complete heart block is generally poor without therapy, like a pacemaker. Patient with first and second degree heart block are usually asymptomatic. Okay, thank you for hearing my case study, complete heart block. for Mr. Nurhan, and our practical base, Hospital Bukit Mertajam. Thank you.